Let's get started. Thanks for your patience. New year, new room. So hope you all like the setup here. We are at Sanger Hall now, second floor above the old Grand Rounds room on the first floor. So thank you all. Today is one of our special quarterly MMI sessions and quality improvement. Today, the focus will be on delirium. So I'll leave this attendance slide up for a second to make sure you text in the code if you're looking for CE credit, and hopefully you can scan the New Innovations QR code. All right, let me introduce our lead moderator here for this panel, who has a panel of distinguished members here with her team that will each come up and present. Dr. Amber Balzer has been a nurse practitioner with the VCU Hospital Medicine Service since 2017 and became the Associate Chief of Quality and Safety for the division last year. She received her doctorate in nurse practice in 2019 with a focus on improving the readability and grade level of patients' discharge materials. In 2023, she was awarded Hospital Medicine's APP of the Year, the Center of Advanced Practice Innovator of the Year, and a Richmond Top Docs designation. She's currently involved in initiatives surrounding delirium prevention, improving transitions of care, and the development and implementation of advanced practice practitioner professional advancement model within VCU Health System. Amber, let's give Amber a round of applause and she'll get it started. Thanks.
Thank you. Good afternoon, everyone. Welcome to our Morbidity, Mortality, and Improvement Grand Rounds, Holidazed and Confused Delirium Prevention Initiative. So as Dr. Bergman said, my name is Amber Balzer, and I'm the Director of Quality and Safety for Hospital Medicine and our panel moderator for the day. I'd like to take a moment to introduce and thank all of our panelists for being here with us. We have Leigh West, a PA with our Geriatric Consult and Co-Management Service, Dr. Melissa Bowie, Assistant Professor of Psychiatry and Consult-Liaison of Psychiatry, Dr. Michael Weissberger, Assistant Professor of Geriatric Medicine, and Dr. Tony Coppola, Chief Resident in Quality and Safety. A quick reminder of the goals of our MMI conferences are to learn from medical errors, complications, or unanticipated outcomes through engaging in conversation surrounding critical incidents, and to diagnose system errors and increase transparency of organizational efforts, not to place blame. Ground rules include no finger pointing, maintain confidentiality, and keep ideas as practical as possible. Our objectives for today are to review a case of severe delirium and how it led to institutional prevention efforts, to understand the impacts of delirium and successful management strategies, to review the development of our delirium risk score and how to add it to your workflow, to discuss the ongoing delirium pilot work and how to utilize the delirium order set, and finally, to review the lab project created by our third-year residents. We have no conflicts of interest to disclose. And so moving into our case presentation, Mr. X was an 84-year-old male with a past medical history significant for vascular dementia, atrial fibrillation, remote urothelial cancer, hearing loss, CKD, and recurrent urinary tract infections, who presented to the hospital with altered mental status and recurrent falls. This was his 6th admission in the last 5 months. Blood and urine cultures were obtained, a head CT was negative for acute changes, and he was appropriately treated with broad-spectrum antibiotics based on historic culture data. His remaining medical workup did not reveal any additional etiology for his presenting symptoms. However, throughout his hospital stay, Mr. X developed prolonged hyperactive delirium, sleep disturbances, and agitation, resulting in numerous falls, assaults on staff, bird alerts, and a prolonged hospital length of stay. This pattern of behavior had been noted in his previous hospitalizations. What differed in this hospital stay was multidisciplinary collaboration, flexibility, and creativity, which aligned to create a safer environment for both the patient and the providing team. Nurses, providers, ancillary services, and intermittently the patient's family were able to come together and create targeted delirium prevention strategies and develop a care plan that could follow this patient through his subsequent hospital stays. For example, it was learned after getting to know Mr. X that he had been a farmer for his entire life, waking up at dawn and going to bed very early in the evenings. So some successful interventions for him included distraction techniques with conversation and videos about farming, retiming his medicines and his lab draws to align with his natural sleep-wake cycles, and utilizing a cozy bed at night. This is only one of numerous recent cases of patients becoming a danger to both themselves and frontline providers due to acute delirium during their hospital stay. I will turn things over to Leigh to walk us through a little bit about the background.
Hi, everybody. Thanks so much for having me. Those of you who work with me clinically know that delirium is something I feel very passionately about. And I hope that our efforts and our ongoing commitment to this project will slowly but surely result in sort of a cultural change that's needed to really make an impact here. So I'm going to start with some basics. Here is the DSM-5 definition of delirium. It's very wordy, but the highlights are that it is a disturbance in attention and awareness that develops over a short period of time, usually hours to days, fluctuates in severity, and it's usually the direct physiologic consequence of a medical condition, intoxication or withdrawal, or most often it's due to multiple etiologies. And I want to highlight that notion. It is a syndrome arising from multiple contributing factors, and it requires multi-component approach to prevention management. So some statistics. The overall prevalence of delirium in medical inpatients is about 23%. In the critical care setting, the pooled prevalence in ventilated and non-ventilated patients is 31.8%, and ventilated specifically 50 to 70% prevalent. In the geriatric population, 11 to 25% of patients will have prevalent delirium like Mr. X at the time of admission, and an additional 29 to 31% will develop incident delirium during their stay. The impacts are far-reaching, we know this. The cost consequences are huge, as much as $164 billion a year in healthcare costs, and that's one of Dr. Hopgood's statistics from a few years ago, so it's probably outdated. Patients who experience delirium are 2.5 times more likely to die in the next year. They develop accelerated cognitive decline, and talking about sort of hospital metrics, they cause an increased risk of falls, extended length of stay, and as we will allude to, increased risk of violence. So inpatients with delirium have been reported as 11 times more likely to experience incidents of aggression when compared to general inpatients. And our institution's assault data revealed that delirium was the #1 contributing cause to assaults on staff. So VCU has a violence prevention task force, and within that, there's a delirium subgroup that we're all a part of, and we proposed a pilot project focused on the prevention of delirium. So let's revisit Mr. X. So I look at this through a bit of a geriatric lens. And so when I read this vignette, this is kind of what I kind of tune into. He's an 84-year-old male with dementia, hearing loss, and multimorbidity, who is admitted to an unfamiliar environment with a possible infection. Numerous unfamiliar people are coming in and out of his room all day, performing various tasks, including sticking needles in his arms, attaching tubes to his private parts, taking him to another room briefly to go into and out of a tube, and then back to his room. If they explained what they were doing to him, he didn't hear it. And if he did hear it, he didn't quite understand. The nurses were kind enough to order his food for him, but the food service person just brought it in and left it on the bedside table and left. The provider team rounded at 11, but failed to notice that his food was in the corner of the room untouched. His family arrived later that day, found a cold breakfast tray still sitting on his table, and a full water cup with the ice melted. So this happens all the time. We've all seen this. And what we don't realize is being in the hospital is disorienting to all of us, that even if we work in healthcare. But for a patient like Mr. X, who already has baseline cognitive dysfunction, he's going through the day without any cues. He's not participating in his care. He's not mobilizing out of bed. He's not having 3 meals a day to sort of help cue him into how the day is progressing. If this goes on, it is, even if he weren't confused on arrival, it's not surprising at all that he would develop confusion while he's in the hospital. So I'm going to make a case for the multi-component non-pharmacologic interventions. It's a mouthful, but this is what we know helps to treat delirium. So this is a systematic review and meta-analysis of randomized controlled trials evaluating the effects of coordinated non-pharmacologic multi-component interventions to prevent delirium. It's the first meta-analysis that included studies where prevalent delirium was excluded at baseline. And then it's the first meta-analysis in a while that included non-ICU populations, which is helpful. So it should come as no surprise that these types of interventions were found to reduce the incidence of delirium with a relatively low number needed to treat. And there was also a trend towards reduction in delirium duration, as well as reduction in length of stay. So when we talk about what are multi-component interventions, so there are multiple different buckets of interventions that these different programs choose to introduce. So on this slide, the green boxes are newly introduced components within that program. The orange/gold boxes are components that were either not introduced or were already established within that institution. So things I want to highlight. Number one, you'll see that only 2 of the programs introduce sleep enhancement. We all kind of know that sleep precautions are important for delirium management. It's the first thing we jump to when we hear a patient is delirious. And so it might be that most of the institutions already had these protocols in place. It's hard to say, but it's definitely important. And our group has worked on some specific projects to try to address it, as you'll hear about later. The other interventions I want to highlight are orientation and cognitive stimulation programs. You'll see that they're included in most of the programs. Mobility is huge and one of the hardest things to accomplish. Nutrition and fluid optimization is another one that's utilized in most of the programs. So this is a busy slide, but these are 3 successful delirium prevention programs. And what I want to highlight here is that all of these programs utilize a dedicated intervention nurse or some sort of specialist who oversees the program, makes sure that the interventions are being implemented in a consistent manner, and also making sure things like delirium screening is being done, and making sure that the nursing staff has the resources they need to be successful with their programs. All of these programs utilize some sort of orienting communication or cognitive stimulation protocol, a mobility protocol, as well as hydration and oral nutrition protocol, and 2 of the 3 utilized sleep. And again, shouldn't come as any surprise, they were all successful in improving delirium incidence. So what are the keys to effective non-pharmacologic delirium prevention and management? Standardization. So we can't only choose which components we're going to institute at our institution, but we have to do it consistently across the board, day in and day out. We also need to have an all hands on deck mentality. This requires a culture change. We can't rely on nursing staff to implement all of these interventions that we're talking about. So how do we involve every single person that enters the room? We need to feel empowered to help set the patient up for their meals if they need help. We need to find ways to alert every single person that enters the room that is necessary. And how do we empower specifically our provider teams to be more involved than just retiming medicines and discontinuing medications, which is very important, but not the end of the road. And how do we do this while minimizing resource utilization and documentation? So that was a big concern that we had as we were trying to roll out this pilot. Early on, so we piloted this program on North 5, we had concerns about our ability and the questionable necessity of rolling out these standardized interventions across the unit. So we started to look into how can we screen for delirium risk. So we'll talk a little bit about delirium risk prediction. In general, the literature is full of data about what risk factors put people at risk for delirium: advanced age, pre-existing dementia, prior history of delirium, premorbid, mood disorders, drug use, substance use, etc. But there is specifically a systematic review back in 2018 that said all of our attempts at prediction models do not adequately predict delirium risk. But we continued to kind of review the literature, and we found a group out of Italy that was able to develop and validate, at least within their institution, a delirium risk assessment tool that they were using in their ED. They looked at numerous variables and found that 7 were most highly associated with delirium. And they then reviewed several different score combinations and found that the combination with the highest discriminative ability was age greater than or equal to 75, pre-existing dementia diagnosis, chronic use of psychotropic drugs, and hearing impairment. This is what their score looks like. A score of greater than or equal to 3 points puts the patient at a high risk for delirium. And so we opted to implement this score specifically into our EMR because it would not increase the documentation burden on either nursing staff or provider staff, assuming that their problem lists and diagnosis lists were updated within the EMR. And so Dr. Weissberger is going to talk more about how we developed the risk score.
So Epic has this tool called a patient acuity score, and it's pretty easily configurable once you learn how to do it. You can make use of pretty much any patient property. So anything that's discretely available in the chart. When I say discrete, that means some value that's not just in the text of a note. And so this particular tool called the patient acuity score, we used it to develop this delirium risk score based on this existing tool that's been validated. It's calculated in real time. So when you view this column in a patient list, it gets calculated. And it's stored to the chart every day at midnight. This particular rule doesn't change through the admission. So it's based on diagnoses and data about the patient that won't change during a single admission. But this type of score can be written for anything that might be changing during the admission, whether it's vital signs or labs or anything else. So these scores are pretty flexible. This is what the tool looks like when you're configuring it in Epic. You can see down at the bottom, there's sort of 4 different what are called rules that are one for each component of the score. So the first component of the score is the dementia component. So how do you tell the patient has dementia, right? We write it all the time in our notes, but the way that Epic prefers us to document patients' problems are in the problem list. As an aside, I'd encourage you all to use the problem list, at least on admission and discharge. Without a problem list that's full and accurate, Epic can't help us with tools like this or many other tools they've got that are based on the patient's diagnoses. So at admission and discharge, at the very least, please reconcile those diagnoses to the problem list. So, but stepping back a little, how do we describe dementia, right? We use ICD-10 generally to diagnose problems in an electronic way. And so we built what's called a grouper in Epic, which is a way to have a group of different concepts. In this case, it's a diagnosis grouper. And so this grouper is built on something called SNOMED, which is a hierarchical vocabulary of conditions. I think it's the Centers for Medicaid Services, I believe, maintains this vocabulary. You can see an example, you can browse it in Epic, an example on the right of this hierarchical nature. So this is the concept of dementia that we added to our grouper. On the left, you'll see the less specific diagnoses, which are, in this case, impaired cognition and mental disorder, organic mental disorder. And on the right are the more specific diagnoses, so things like Alzheimer's disease. And so all of those more specific diagnoses would be considered a dementia diagnosis that would trigger or that would add into this delirium score. We also added the 2 diagnoses, cognitive impairment and mild cognitive impairment. This kind of deviates from this particular study a little bit. We noticed that there were quite a number of patients who had those diagnoses in their problem list who actually did have a dementia, and we were missing a lot of that. And so we made the decision to deviate a little bit from the risk score that was previously studied. So then the other components, hearing, this is a little easier. It's documented in the flow sheet by nursing at every admission. There's 2 different places they documented in the basic assessment flow sheet and then the ADL flow sheet, or if there's a hearing loss problem that makes the score decide that the patient has hearing loss. If the age is greater than 75, that's an obvious one. It's pretty easy to tell. And then the medications. The piece of medication is a little more challenging. And so we made the decision, I have another slide on this later. We made the decision to count medications that were active on a patient's med list, even if they were so-called expired. So you've probably all seen that little expired next to a patient's medication in the list. What that means is that someone at some point marked that as a long-term medication, a chronic medication, but perhaps no one has prescribed it in our health system in the past year, or the prescription that was prescribed has run out. But they should still be taking it and likely have a prescription from somewhere. And so we made the decision to include active medications and expired but chronic medications from these classes. So these classes, as previously mentioned, were the classes of medications that are considered to increase the risk for delirium as per this score. And so here's a little bit more on that. You can see there at the top there that coenzyme Q medication that's been struck through, that's been discontinued. So that wouldn't be considered a medication that would this risk score would consider. But that medication there that says furosemide expired, if that were a psychotropic type medication, even though it's expired, it would consider to be active because we assume someone has prescribed it as they have been, as it's been marked as long-term. There's all sorts of difficulties with these medication reconciliations. And if you're trying to do it automatically with a score like this, you kind of do the best you can. This is a histogram of the distribution of the risk scores at North 5 over the past 6 months since we administered, so to develop this score. There's been about 867 discharges, and about 20% of those are positive or 3 or higher. And so you can see there's about 20%, about 1 in 5 have 3 or higher score. So it's a pretty interesting tool in that we get to exclude a lot of patients who are lower risk for delirium. And this is what it looks like. So on the left, you see a patient list there. You can add this score column to your list if you like. To do that, you right-click on your patient list and hit, I think, properties. And then on the right there, top right, you can see you type in delirium and choose that delirium risk score column, and it'll populate for all of your patients. If they don't have all of the diagnoses in their problem list or previously billed as a visit diagnosis somewhere, so an ICD-10 code, then you won't get that dementia piece, but everything else should work for you. We also added it to the geriatric handoff. There you can see in the bottom right, there's a little delirium risk score, positive or negative. So it automatically populates for all of our patients in our handoff. So if you'd like to talk to me after about these scores, we can certainly develop additional scores pretty quickly. You can get a hold of me or the physician informatics team about it. And hand off to Dr. Leigh.
All right, thanks so much. So I now get to sort of recap some of what we've talked about and build the case for our pilot. So by this point, you've heard about what delirium is, who develops it and why, and what the long-term consequences are, including significantly negative clinical outcomes, hugely increased costs, and violence against our staff and frontline providers, which was really sort of the driving motivation for us to create our group and to do this work. You've also heard about evidence-based strategies to either prevent delirium or implement early intervention strategies. And the nice thing about delirium, as talked about by Leigh West, is that delirium responds to prevention and early intervention strategies. So if these are things that you can implement, especially if you can change the culture around them, you can significantly improve patient outcomes and a lot of downstream effects. And these are not complex interventions. They're actually fairly simple interventions, things like early mobilization and having a mobilization plan, optimizing their sleep-wake cycle, encouraging adequate nutrition and hydration, and cognitive engagement, including frequent reorientation. We've also learned about the role that delirium has played in assaults against our staff, which has served as this motivation to be doing this work. Now, where would we do this pilot? We've been collaborating with nursing staff on North 5. They've been very open to collaboration and these sort of innovative developments. They've piloted quite a few different measures, but they've been wonderful partners in this work. And the timing of our work, based on sort of when we started thinking about this and the time it took to organize our our mission and build our tool, we began our work in the summer of 23. So that leads us to the question of how. How do we do this? How do we change the culture? And with that, I'd love to take a quick detour and talk about seatbelts. Now, seatbelts are commonly used. We all use them every day, every time we drive. If we are driving our kids or somebody else's kids, we're always buckling them in and making sure that everybody's safe. We sort of take this for granted. This is part of our culture, but it didn't always used to be. Seatbelts were first rolled out in 1885. The current design, the sort of three-point design, was developed in 1959 by an engineer at Volvo. They didn't patent the three-point design. They actually distributed it for free because the value of lives saved was so much greater than any money they could have made by selling the design. It was first federally legislated in 1968. That's when cars manufacturers started to have to put them into their models. And people actually responded by cutting them out sometimes. There was such a strong opposition to being told that the seatbelt was now part of your car design. People really did not like that. So they remained unpopular until 1985, and that really is the beginning of this change. In 1985, the estimated use of seatbelts was 14%. 14% of drivers and any passengers in the car, 14% of them were using seatbelts. So how did this change? It wasn't until there was a huge push, both from cultural changes, legislation, and some lawsuits from insurance companies who stood to lose quite a bit of money with seatbelts not being used, that these changes were sort of culturally adopted and implemented. By 2010, 85% of drivers and passengers were using them, and by 2019, it's 91%. So really not that long ago was this very, very different. And I bring this example up because I believe 20 years from now, 30 years from now, we're going to look back at today about delirium the same way that we look today at the failure to use seatbelts from 20, 30 years ago. It's such a simple thing. Management of delirium, prevention of delirium is such a simple thing. The benefits are enormous. And if we're expecting people to do it on a one-by-one basis, we're not really going to get that benefit. But if we can change the culture, if we can have a number needed to treat of 12, if we can change populations of care, then we are going to change the outcomes for our patients and for our healthcare system as a whole. And this is where we can start that, and we can make those changes, and you can make those changes. We can all have all hands on deck. So how do we make this change? We want to change the culture. We want to change the culture from the top down and from the bottom up. And we want to integrate those changes into the established workflows to minimize added effort. If we can use a tool that you can see in Epic automatically in your screen, that's no added work for you. That's something that you can automatically change. If you can implement some of these order sets into your workflow, if you can walk into the patient's room and know that they're high risk or that they're delirious, and reorient them to situation and day and time and what's going on. If you can offer them a sip of water, if you can help facilitate some of these things, make sure they have a mobility plan in their daily care plan. So what steps did we take to do this work? Well, we refocused the efforts of our subgroup around this project. We've had administrative support from Emily Holt, who's been a project coordinator for the Department of Internal Medicine that has been invaluable in moving this work forward. We created a charter to organize our work. We developed something called a prevention of prescription, which outlines those 4 key areas that I mentioned: mobilization, sleep, cognitive engagement, and nutrition and hydration. We built the screening tool directly into Epic. You can use that, populate it on your screen. You can also look at Delirium All, which also tells you about delirium scores, whether they're CAM positive, CAM-ICU positive, CAP-D for pediatric patients. We utilize something called the notes to clinical staff on the front page of the patient's chart to use a smart phrase to inform anybody who looked in the chart that this patient is either at risk of developing delirium or already delirious. And we developed the delirium order set. Now, this was something that we had in Cerner that did not get carried over into Epic. Initially, we had some resistance to building it because of other Epic priorities. But again, through some of these top-down interventions, we've been able to rebuild it to have it available as the adult delirium order set. And this includes both pharmacologic interventions for agitation and also non-pharmacologic best practices. For our first cycle that started September of 23, we had a lot of wins. We had great partnership with North 5, interdisciplinary engagement. We've had a number of deliverables from this, as we've talked about, including some prevention and delirium education materials. And we've had some really great collaborations with colleagues, thinking about opportunities for trainees, thinking about opportunities to collaborate with other QI work. We have many areas for improvement, and we're eagerly looking forward to this next cycle of the model. We recognize that the division of labor needs to be re-examined. We want to make this sustainable. We also want to make it scalable. We want to make this something that any unit in the hospital could implement if they would like to. And we want to be there to support them to do it. We want to improve our family engagement and also our clinician engagement. So utilizing the model, having that all hands on deck mentality, and knowing about these order sets that are available. And we wanted to make it a little bit more memorable. And so for that, we've introduced this snail meme, and we've called it escargot. And the acronym for this really outlines these things that we've been talking about. Highlighting A, all hands on deck. Again, this is a culture change. We all have to be a part of it. We also want to increase the involvement of our consult services. Geriatrics and psychiatry consult services are always happy to be involved. If they're not, tell me about it. Tell me about the psych consults, because I'd like to hear that. But we want to be involved. If you have a patient with agitated delirium, please get a geriatrics consult. Please get a psychiatry consult. We would like to help. So for our first and second cycle, you can see here some of the changes that we're building in, that we want to bring nursing leadership into a central role in screening. We want to bring family into a central role in helping us to know more about their loved ones. We want to use these order sets and use targeted educational campaigns to let people know about them. We want to use those clinical staff updates to continue letting people know that this patient is screening in, finding the right people to do that work. And we want to continue to expand our collaborations. With that, I'll pass it to Tony Coppola to talk about the PGY3 class.
Thank you, Dr. Bowie. So to finish off our MMI conference, I'm going to be talking about the PGY3 class project. To start with a little bit of background, every year, the third year internal medicine residents choose a class quality improvement project. The residents then work on this throughout the year during their dedicated 2-week quality improvement rotation. As you may know, the majority of house staff medicine teams are located on North 5, and so many of our residents were aware of the Delirium pilot and wanted to collaborate. Specifically, the residents were interested in the large role that sleep plays with delirium and wanted to focus on minimizing nighttime interruptions. To do so, they felt the timing of routine lab draws would be a great starting point since our default collection time is 3 a.m. So with a focus on lab collection time, they began collecting baseline data on the North 5 medicine teams. So to do so, there was random chart reviews, and they collected data on over 60 patients. And as you can see here, there were 60 total lab draws. Of those 60, 54 occurred during the night shift, so 7 p.m. to 6 a.m. And as you can see here, 100% of the night shift labs were collected after midnight. We've talked at length about the delirium risk score. And so since we were collaborating with the pilot, we stratified by whether the patients were positive and were at risk for delirium. So as you can see, of those 60 lab draws, 13 of them were in patients at risk of delirium. Of the 13, 11 of the labs were collected during the night shift. And once again, 100% were collected after midnight. So with this baseline data in mind, it was obvious that there was room for improvement. And so the specific project we came up with was increasing routine lab collections before midnight. And our specific aim was to increase the percentage of routine night lab collections before midnight from 0% to 50% in patients hospitalized on North 5 house staff medicine teams over a 1-month period. To do so, we came up with a multimodal intervention plan. The first was development of Epic lab orders that would default for a time of 10 p.m. These were named bedtime labs instead of the default of 3 a.m. The second was giving education at our ward orientation to the house staff regarding the project and the option to choose the new bedtime labs. And last, but probably most importantly, was collaboration with the North 5 nursing staff regarding the project and the new workflow. As discussed, we ran our first PDSA cycle over a 1-month period. During that time, we collected data on over 159 lab collections, and we were thrilled to see improvement. So as you can see here, once again, the majority of the lab collections were during the night shift, 7 p.m. to 6 a.m. And as you can see here, we were able to improve collections before midnight to 54%. So we had reached our goal. Once again, stratifying for patients at risk of delirium, there were 36 lab collections, and we were once again able to improve collections before midnight, and we reached 61% in patients at risk of delirium. Since that first PDSA cycle, we've continued with bi-weekly data collection to assess for sustainability of our interventions. And we're happy to see that not only is the project sustainable, but we've seen continued improvement. So now you can see we're up to 78% of the night lab collections are occurring before midnight in all patients. And we're up to 82% of night lab collections are occurring before midnight in patients that are at risk of delirium. So overall, we're incredibly excited about the success of our project. Given how sustainable it's been as well, we're trying to use this momentum, and we'd like to expand the intervention to additional house staff teams. So we're planning on expanding in a few weeks to medicines team 3 and 4, which are located in North Hospital as well. If we continue with success, we would like to look to implement this within the Division of Hospital Medicine, which shares clinical space in the North Hospital. We'd also love to continue working with the Informatics team. They're the ones that help us build the bedtime orders. It would be great if we could incorporate those into admission order sets. Right now, they're just isolated searchable orders. Last but not least, we would love to correlate these results with another metric. The success of the project is difficult to show if we're moving the needle on delirium because we talked about how that's multifaceted, but we'd love to find another clinical metric. And we're considering something like patient satisfaction, seeing if patients are satisfied with the earlier labs compared to the default of 3 a.m. And finally, to end, I would just like to give a special shout out to the entire PGY3 class, Dr. Eric Schaefer, Dr. Alex Rittenberg, Dr. Evan Ritter, Amanda Magruder, and Eric Carpenter. Thank you.
And to wrap things up, as you all have heard, delirium is unfortunately both extremely common and costly, both to our patients and the institutions in which they are receiving care. Delirium is the #1 contributor to assaults on staff here at VCU, and prevention strategies are generally quite simple: mobility, nutrition, sleep, reorientation, and yet somehow they are not routinely a focus of our inpatient care plans. So we need an all-hands-on-deck, interdisciplinary, standardized approach to delirium prevention and management. You saw several successful external endeavors that all had dedicated team members that ensured their success. And so we've made a lot of progress with our risk prediction, order set, lab retiming, and pilot work, but we still have a long way to go. We're very thankful to have had the opportunity to spread awareness and understanding to help improve the health and long-term outcomes of our patients. And if you're interested in learning more or getting involved with our team, please reach out to any of us. We'd be happy to hear from you. Thank you. I can invite everybody back up if you want, if there's questions or if we're out of time.
You can open it up to the floor. Let me just figure out how to turn on the mics in the room. Give me 1 second. But they're on. It's green in the ceiling, sorry. Go ahead. They'll be able to hear you online.
First of all, thank you so much everyone for this great talk about this very important topic, which is learning information. My question is mostly for Tony. It's great to see the success and the implementation of the QI project of the retiming of the lab. I would also be interested in seeing the impact of the success of that project on the prevention of delirium. So have you all looked on the incidence of delirium after rechanging the lab time and the collection time on the patient?
Yeah, so I think the challenge, like we said, is delirium is multifaceted and sleep is just one component of the delirium. And so it's been difficult to show that our efforts have caused some measurable change in the incidence of delirium. That's why we'd like to kind of shift our focus to find some other clinical metric to correlate our efforts.
Thank you for your talk. There is one study I read 10, 15 years ago when it looked at what patients felt was most disruptive to their sleep. And the number one was actually the blood pressure. Not getting vital signs in the middle of the night is much more difficult than being able to change the time of a blood draw. But is there any thought of looking at that, or patients who don't need them as much or as often, cutting down on that?
I think there's a lot of institutional effort to try to visit a patient's level of care every day. I know some of our North Hospital units are rebuilding our CDR rounds, or kind of rounding with the nurses and addressing things like, what is this patient's level of care? Can they be downgraded to acute to do exactly what you're saying? But it is difficult to, maintain that widespread. But
the prediction index seems like a very powerful tool. So if we're not on North 5 and we start utilizing that, does the delirium order set start to include some of those behavioral interventions that we implement to be able to prevent delirium?
Melissa, I think, can speak the best to the content of it, but yeah.
Yeah, so you're welcome to add it to your view to be able to see it and to use that to sort of gauge appropriateness of some of these other interventions, although these are interventions that wouldn't be harmful for anyone, so certainly could be adapted. The adult delirium order set does include some prompts and guidance. It includes things like reviewing medications, thinking about melatonin for sleep. I think it includes a PTOT consult. So it does have components of the intervention built in. I think less well represented would be frequent reorientation and cognitive engagement. But absolutely, you could use the delirium order set for patients that are either at risk or who are already delirious. It also has some smart features built in. So the antipsychotics in the order set for agitation are set to expire. I believe it's after 2 days, so that the patient isn't on antipsychotics indefinitely. The delirium, the other column that can be helpful to keep track of is the that other one that we mentioned. I think it's called Delirium All, and that includes the CAM or the CAM ICU or the CAP-D as a delirium score. And so that will show up as a red plus sign if the patient has been noted to be delirious in the past 12 to 24 hours. Great.
I think you were first.
Go ahead.
Okay, thank you guys for all this important work. I appreciate it. I wanted to ask if there had been any discussion about in the future expanding the pilot to other sites. I work at Tappahannock, and our patient population is almost all 65 and older. So I think that, they certainly would benefit from a lot of these interventions. So, the number of patients we see out there is a lot lower compared to VCU downtown and the data from there, but I do think that they certainly would benefit from a lot of the interventions you guys are doing.
We had not talked about that just yet. We are kind of working on narrowing our next steps for our ongoing cycles. I think all of us entered this extremely optimistic and wanting to solve delirium for everyone. So that's most likely not going to be feasible without a plug for a dedicated staff member. I'll put that out there to work on things, but we are revisiting the pilot post holidays and trying to figure out how we can expand it here reasonably with our staffing, finance limitations.
You should be able to use the risk score.
Okay.
It depends on how the nursing is documenting their hearing impairment. So you can look at it, but you should be able to add it to your file.
Okay, great.
And that delirium order set, my understanding is that was also
Should be
rolled
active
out
everywhere.
enterprise-wide.
Okay.
Yeah.
Awesome.
And our goal with this is that we want to use the next cycle and the next sort of couple of cycles to really finesse what the model looks like so that it is just ready to go. For any unit that says we're ready to do this, we'd like to take it on,
Right.
that we'll have sort of all of those steps laid out, that it's just crystal clear and sort of very self-starting.
Thank you.
We also have numerous dot phrases and like standard language that we use that you're always welcome to reach out for the specifics to spread the gospel, if you will.
Yeah, sure.
Because that's some of what we use on like the notes to clinical staff is just like, this patient is delirious, do all of these things.
Right.
And it's just trying to touch as many people as possible rather than just having it in notes.
I'd like to point out that you just spread the gospel to the world. We use a lot of delirium. We use the CAPD scores, we have it within our basic order steps, lights on, shades off at 8 a.m., that type of stuff. But this delirium risk score idea is fantastic. And obviously a rage 5, 75 is not going to work out here. But I do want to learn more about that and how to create lines.
You can basically make one of these risk scores for any topic,
That's what
any,
it sounds like.
not just delirium, anything. So I'm happy to.
Once you got that CAPD score, they are already delirious. This will kind of pinpoint to us, who do we need to be at and preemptively do support.
That's the goal.
So help me advocate, great work, by the way, thank you for focusing on this, really important for the patient. Help me get resources for it. So have you been able to show that you can move the needle in our patient population by all the things you heard? Are you encouraged enough to show that unmodified reduced delirium rate? Great. I know we talk very specifically about psycho, but all the other things you're doing, are you able to have enough data to show you're using that?
No, and so I think some of our next steps, we can use this score in theory, and you all can correct me if I'm wrong, to identify those at risk for developing delirium. So the next steps are to say, okay, who of those patients who we said they are at risk go on to develop delirium, and then what can we do about it from there? So I think we need to, and there are lots of loopholes there. Our CAM screening is inconsistent at best outside of the ICU setting. So there's a lot that needs to go into the next steps, but I would be happy to tell you about it when we get there.
That's sort of analysis that we've been thinking about doing, using some proxy for delirium, like their CAM, obviously a good cool tool to use to diagnose delirium, but also any PRN psychotic use and restraint use and one-to-one use, those sort of orders, the presence of those orders, and comparing the cohort of patients who have high risk for delirium. Those are places that we're hoping to look at.
Yeah, I think it'll be an area for scholarship. Yeah. And I think one other question, but you focused a lot on the inpatient work, but this patient's been admitted 6 times or 5 times in 6 months. What advice should we be giving to the family? These obviously very high risk in the future for readmission, so that they can take the advice back to the community. And that's not people other.
I'm not sure if you were Leigh.
You're smiling. That part was right.
No.
No, I think it's a great thing.
I think it's going to get alligated and probably.
And it's going to happen again. You know, I think one of the challenges that we've had in some of this work and that we've had to keep revisiting this exact question is delirium is such an overarching and encompassing problem. It sort of takes over and worsens so much else. It's such a big thing to take on, and it's really hard to narrow it down. But I think there are ways to communicate about delirium to family members, and to explain sort of what it is and that it increases the likelihood that it would happen again. There is a metaphor that we'll often use sort of talking to families, and that's of a snow globe, describing how if you think about the brain as a healthy working brain as a snow globe with all the snow at the bottom, any sort of pre-existing medical problem, chronic issue, alcohol use, psychiatric disorder, anything that we know increases the risk of delirium sort of loosens up that snow at the bottom. And then whatever led to them coming into the hospital, like an MI and respiratory failure, mechanical ventilation and all sepsis and all these things, that's how hard the snow globe is shaken up. And that any subsequent, and it takes all that time for the snow to come back down to the bottom, any subsequent shake is going to lead to delirium that much faster because it's already so loose. So I think that can be a helpful way for families to just wrap their heads around this very complicated thing and say, this is not permanent. It doesn't, you know, this can resolve, but we have to address all of the underlying issues, and it's going to take time. And the fact that it happened this time means it's so much more likely to happen the next time and the next. But delirium does tend to sort of follow itself. It tends to look similarly each time, if not worse, so that the family could know, okay, this is what worked this time, and that they can take that initiative to have a get to know me page about these kinds of things and educate them. So I think education to families is a huge piece, and something that we have also sort of tried to loop in, but again, trying to keep ourselves narrow while still sort of taking on the whole big thing. Yeah.
One thing just to tie off of that, I know you guys are, there's a lot of different stuff you're looking at, but there's a heart failure order set that has recently come into play, and part of that, when you use it and identify patients who have decompensated heart failure, when you go to discharge them, it has automatic checkboxes for patient information. So at some point, I don't know if that's something that you could consider down the line to look at for patient education on discharge about delirium and family resources and those sorts of things.
It's a great idea.
But,
yeah. And I think if any residents or, you know, anybody would like to partner with us in taking any of these pieces on, we would very much welcome it and celebrate that, because I think we're hearing these great ideas that would be wonderful additions. And just to sort of circle back about the delirium piece, I know there was one resident that was interested in sleep and development of delirium and might be interested in partnering and looking at delirium-free days as a result of this. So again, the opportunities for scholarship are enormous. So we would welcome any collaboration.
You know, opportunities for collaboration, I'd say that the Department of Ed, you know, positions, we have a School of Education. How do you produce even interesting educational tools for families? I think there'll be a lot of things. Obviously, everybody's the day job, you're ready. You're writing like 66 grants on this.
More the merrier.
One aspect I think is important to look at is the violence one. And I know OSHA is really focused on violence in a hospital setting. And the last time I looked at the statistics, it was that of the 100% of reported violence is non-fatal workplace assault, be it police officers, prisons, schools, you name it. Hospitals made up 48%. Half of all workplace violence happens here in the hospital. And I've never read exactly what is the number one cause, but delirium, I'm presuming, is the number one cause. So if you can move the needle just on that, I think hospital administration will be very happy. Because I know they're under, all hospitals are very much pushed by OSHA to decrease this violence.
And I know we're pushing our time, but there was just a couple questions in the chat. Someone said, any discussion about balancing measures for bedtime labs? Curious how timely the response will be on night shift to abnormal labs versus how often are the bedtime labs normal and maybe not indicated anyway. Have to imagine IV potassium would be more disruptive than a 3 a.m. lab draw. And that kind of ties into the next question, was whether there was any feedback from the night team about the potentially increased workload related to the nighttime lab draws if we're then ordering repletions, which maybe the day team would otherwise normally have done. I don't know, Tony, if you have
I
any.
think that's a great question. It's something we've thought a lot about. So we reached out to our night residents and, one thing I talked about was the collaboration with the North 5 nursing staff. And so there's been like a directive that we really should only be repleting critical labs, only reaching out to the night team about critical issues. And so overall, we've had great collaboration with the nursing staff, and it hasn't added a lot of like workflow burden. But that's a great question.
And Amanda echoed your thoughts in the chat, exactly. So. I think some of these are similar to things we've already addressed. Someone said the ED would seem to be an extreme case of delirium-inducing conditions with noise, lights, confusion, constant interruptions for labs and other purposes.
Actually, this score was developed for use in the ED.
Mm-hmm. Yes, and this score, if you couldn't hear online, was developed initially for use in the emergency department. And last comment, at my last workplace, we had human-looking robots that could be placed in the room with patients dealing with delirium that engaged them in interaction in the day, and also had a camera that sent images to the nursing desk so the patient could be monitored. Maybe a role for AI and robotics. That is extremely interesting. Some ICUs are using robotic pets. Looks like a cat.
That sounds like a Black Mirror episode.
Exactly. Fantastic. Well, thank you, everyone. If there's more questions, feel free to reach out.
Thank you. Thanks, everyone. Appreciate it. Take care. Have a good day.
Really great. I love how you stratified it.